This is NatSec Matters.
I'm host Andrew Shapiro with Beacon Global Strategies. Today, I'm joined by Dr. Michael Osterholm, Regents Professor and Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. Dr. Osterholm also serves as a Senior Advisor to Beacon Global Strategies. He is one of the nation's leading voices on pandemic preparedness. Dr. Osterholm joins us today for a discussion of his new book, The Big One: How We Must Prepare for Future Deadly Pandemics, where he and co-authored Mark Olshaker shed light on the impacts of the COVID-19 pandemic and assess the threat of pandemics going forward. Stay with us as we speak with Dr. Michael Osterholm. Dr. Osterholm, welcome to NatSec Matters. We're delighted to have you here.
Thank you. It's great to be with you.
Now, you and I first met during the COVID pandemic when you helped advise Beacon Global Strategies during that period, and you have a lot of expertise on infectious diseases. What I'd like to do today is to talk a little bit about your background and how you began your work in infectious diseases and some of the highlights of your career, and then we can talk about the book, and then what lessons the book has for the future. So to start, how did you get into the field of epidemiology, and what led you into the study of pandemics and pandemic preparedness?
Well, first of all, let me just say that my love of public health has spanned my entire 50-year career, which is I'm now in that point. But how I got involved originally was I was born and raised in a small Iowa farm town. My father worked at a local newspaper as a photographer there, and the owners of the newspaper, a husband and wife team, were subscribers to the New Yorker. I think they were probably the only subscription in all of Northeast Iowa at the time. And by one day, I just by chance happened to pick up the New Yorker when I was at their house. And it had an article in it by Burton Roger, who wrote a whole series of medical whodunit kind of stories that were in the New Yorker. These were real outbreaks that the CDC had worked up, and then he made it into a story. And I was just absolutely smitten at that point with reading that story, and to the point of where every time a new New Yorker arrived, after they were done with it, I would quick run up to the house and get it if it had an article from Burton Rocher in it. And so from that perspective, I knew in 8th grade I wanted to be a medical detective. And everything in my career, training-wise, was focused on that area. I came to Minnesota in 1975 in graduate school, and that was at a time when most people said, why are you going into infectious diseases? They're done. This horse and buggy stuff, okay? And of course, that was not the case at all. And so I started the Minnesota Department of Health while I was in graduate school in 1975. I was there for 25 years while at the University of Minnesota. And then in addition, I then came to the university full-time and started the Center for Infectious Disease Research and Policy. I became very interested and, frankly, quite concerned about our preparedness for a potential pandemic, dating back to my earliest work with bioterrorism, because I realized that what was likely to happen with a large bioterrorism event would also be precedent for what would happen in terms of an influenza pandemic, which we'd had a whole series of them dating back to antiquity. Even though we couldn't grow the virus, the epidemiology seemed very consistent. And so I was very involved with the issues around bioterrorism in the 1990s into 2000. In fact, I wrote a book, Living Terrors, What America Needs to Survive the Coming Bioterrorist Catastrophe, that was published on 9/11 of 2000. And I think I bought 14 of the 18 copies sold in the next year. And then, of course, 9/11 happened with the anthrax. And at that point, all things changed. I actually also, after 9/11, Tommy Thompson, then Secretary of Health and Human Services, asked if I'd come to D.C. And be a special advisor to him on bioterrorism issues. So for 3 years, I split my time between Minnesota and HHS. And that's important in the sense that that's where I was very involved with influenza preparedness activities. And as well as I ended up becoming very familiar with coronaviruses. I was involved in 2003 with the investigation of SARS that occurred out of China. Fortunately, it was a virus that while it killed 10 to 15% of the people who got infected, it was not very infectious except for a very few high transmitting individuals. So we were able to stop that. In 2005, because of H5N1 emerging in the flu world, I was back in Minnesota now full time. I actually orchestrated a more unusual outcome, you might say, of all of this, in that I got the New England Journal of Medicine, Nature, and Science magazines all to publish the same article on the same day, really highlighting the need for pandemic preparedness, which we really had nothing in this country to help us along with that. Well, so much for that. Things improved somewhat, but not much. And then along in 2012 comes MERS, Middle Eastern Respiratory Syndrome. That was one that originated on the Arabian Peninsula. I had been serving as an advisor to the royal family of the United Arab Emirates, and so I was actually on the Arabian Peninsula working on MERS. And what was really telling about it was the fact that it, in fact, now, like SARS, didn't spread that effectively, but it killed up to 35% of the people. So when COVID unleashed its horrible impact on us, really I saw right away that a coronavirus could, with being highly infectious, could bring this together. And let me just sum this all up in the fact of saying that COVID only killed, and I say only with great pain, about 1.5% of the people that got infected. However, it was highly infectious. We now have identified coronaviruses in the wild, in animals, that have the infectiousness of what we saw with SARS-CoV-2 or COVID, and have on board packages genetically that would make them likely to kill at the same level that we might see with SARS or MERS. So imagine, instead of having 1.5% of the population dying with COVID, you now had a new pandemic where you had a highly infectious virus that killed 20 or 30% of the people. That may sound like science fiction, a horror movie, but in fact of the matter, it's actually very true.
In the aftermath of the COVID pandemic, you decided to write this book, the big one. What motivated you to write it?
Well, actually, I started considering the book way back in 2020 because I was already seeing a number of things that I thought were not in the best approach to what we needed to do to control this pandemic. The first thing was, in fact, very few people understood that a pandemic like this was not going to be like a hurricane. It was not going to be horrible, horrible, horrible injury for a period of 16 to 18 hours, and then we go into recovery. And in fact, on the Joe Rogan podcast that I was on March 10th of 2020, I got nailed pretty hard among colleagues for being so scary, but I said at that time I thought we could easily see 800,000 deaths in this country in the next 18 months. Not next 8 weeks, but 18 months. And in fact, we were at 790,000 deaths 18 months later. And we didn't plan for that. We planned to go into almost immediate control and response, which I knew with this virus you couldn't do without a vaccine. Case in point was in late March, when everyone finally recognized this was a pandemic, 41 states issued what were called lockdowns, a term that has been greatly abused and misunderstood as to what really happened. Of those 41 states, a state like Minnesota issued a stay-at-home order by the governor. However, they exempted essential workers, which was 82% of the workforce. So, I mean, it wasn't really a lockdown. But what happened was nobody realized that we couldn't stay really locked down for 18, 24, 36 months. And at that point, based on that, I kept advocating that we get rid of lockdowns as it was known, and we go into the snow day mode. And we talk about this in the book. And with the snow day, what we're really using is our best tool to fight serious illness, hospitalizations, and deaths, and that is good medical care. And when a hospital is at 140% capacity, no one's getting good medical care. People are going to die. So what I'd proposed is to say every day, every hospital in this country should have to publish their actual census. Well, they had 80% full, 90%, 120%. And when we got to a certain level that everybody in the population would know what it was, 90, 95% occupancy, at that point we would ask people to go into a snow day mode, to say, please, for this limited period of time, withdraw from major public events. This is now the time to consider closing schools. And that was met with such a, how shall I say it, yawn at best people didn't realize that we were going to have to keep fighting these surges of virus activity for months and months to come. And as you and I have discussed before, whether you died in the first 6 months or the second 6 months or the third 6 months or the fourth 6 months in a pandemic, you're still pretty dead at the end of the pandemic. And so what we needed to do was have a sustainable issue, which snow days would have helped us by that. And once the vaccine came, then we could move on to it and use that as our primary weapon. But it was things like that that made me realize, boy, we surely need to have a hot wash here. I was hopeful because in my time at HHS after 9/11, I was able to participate in some of the early days of the 9/11 Commission and provide information to them. And I was so impressed with how that entire operation ran, with two really distinguished politicians, a Democrat and a Republican, leading that commission. They did a great job. There was no finger pointing. There was no blame. It was about what went wrong, what went right, how could we do better. And I think that we're all hopeful that that would happen with COVID. And of course it hasn't, and I'm sure now it won't. And from that perspective, this book was really all about, well, this is my best shot at trying to provide what could have and should have been learned.
So provide us with an overview of the book and your perspectives on its timeliness now.
Well, remember, anytime you write a book, you have to have it done for about 6 months before it gets published, okay? So we were finishing this book literally at the time that the new administration was coming into play. And so we have some comments about what that might mean with vaccines and so forth there. But I think that what it really is all about is in preparing for future pandemics, that only works if you're prepared for today. And we have a real challenge today because we have seen a fundamental reordering, you might say, of public health. Right now, the CDC is but a figure of what it once was. We have operations, for example, and I discussed this at some length in the book. Vaccines are really good, but they're not great. What is great is vaccinations, getting people vaccinated. And one of the challenges we have is, regardless of how good the vaccine is, if you don't have it or people won't take it, then it's not effective. Well, if you look at influenza today as one of the two major likely viruses that would cause the next pandemic, and for that matter, still cause a lot of illness right now. I mean, just as note, just yesterday it was announced that 285 kids in this country died from flu during the last flu season. 285 kids. Incredible. So, but if you look at influenza and say, how do we be prepared for a pandemic? We're still using embryoed chicken eggs to grow most of the virus for our vaccines. This is a 1940s technology. And in the period of 1 year to 15 months after the pandemic occurs, if we suddenly geared up and everything worked just right, where we could get into the chicken eggs, et cetera, move things along, we would only have enough vaccine for about a quarter of the world. Well, lo and behold, along comes mRNA technology, a technology that's been researched now for more than 15 years, one that has tremendous promise, not just for COVID or for influenza, but a number of infectious diseases, and very specifically for types of cancer. So we looked at the fact that wouldn't it be great if we could then engineer an influenza vaccine using a mRNA technology approach. And that would bring us enough vaccine in the first year of the pandemic to vaccinate the whole world. And the difference between those two scenarios are millions and millions and millions of lives, okay? So at that point, there was an initiation, a program initiated in the previous administration to move $500 million into having that influenza vaccine ready to go and having, in fact, manufacturing capacity warm enough so that it can be quickly moved forward. And unfortunately, as you know, the Department of Health and Human Services decided to withdraw all that support. It no longer exists. And while there's some work going on at the Defense Department right now in mRNA technology, largely our government's abandoned it, which leaves us back with the influenza vaccine situation I just mentioned. We would have a very, very hard time responding to an influenza pandemic in the near term.
You, in the book, the subtitle is How We Must Prepare for Future Deadly Pandemics. And the book suggests that, another pandemic is inevitable. Is there no surveillance that can be done that, can help prevent these pandemics from spreading? Or is it your view, given today's, world economy, we should expect it, and that's why we need to prepare for it?
Well, first of all, pandemics happen when a virus with wings, I call, namely influenza, was clearly the one that we had implicated over the years, the 1918 one being by far one of the more severe in the last few hundred years. But in fact, we now know that coronaviruses also are viruses with wings, and they can too transmit very quickly via the respiratory route. And when we're talking about the respiratory route, we're talking about just air. Every day when you and I take a glass of water from our faucet, we assume that that water is safe. We generally assume that much of the food we eat is safe, etc. But no one ever talks about what's in the air. Well, today, in the crowded nature of humankind, we transmit viruses all the time in the air. If you're in a room with me and you're sitting within 6 to 8 feet of me, you're basically at risk of inhaling my droplets, the big drops that you see if you're in the first 2 rows of a concert or a play, and you see the singer or the speaker, basically they're coming out. They drop quickly to the ground, 6 to 8 feet. It's the things you don't see. If, in fact, on a given day you're in a room where the sunlight is coming in, you can see all this stuff floating in the air that you have no idea is there all the time. That's an aerosol. Aerosols are those kinds of movements of air, very minute air particles that is just like if you're walking down the street and all of a sudden you smell a cigarette smoke and you look up 30 feet upwind from you, somebody's smoking. That's an aerosol. They can travel long, long distances. Once a virus in the influenza or coronavirus families start to transmit person to person with no previous experience, meaning we don't have any immunity, that virus moves really quickly. And viruses with wings are such that by the time anybody even knows it's happened, it's gone. A good example is with COVID. When it first emerged in Wuhan, this country immediately responded by trying to fortify the West Coast. A lot of screening went into place at ports of entry, et cetera, et cetera. Meanwhile, people forgot about the fact that the virus is going the other way too. It went from China to Italy, other areas of Europe, and soon it was in New York City. And it had come in the East Coast, not the West Coast. It was moving that fast, and it was around the world in days. And so once this virus leaks out, it's out. Now, in the book, in order to help people understand that, we actually start each chapter with a continuing scenario that begins in the very first chapter of how a pandemic with one of these coronaviruses, a more lethal killer, would actually emerge from, in this case, in Somalia, and how fast it would be in many locations around the world before we even realized what was happening. And so, yeah, you can't stop these viruses by just detecting them early. That'll help get you better prepared from a vaccine standpoint to move on vaccine development, but it won't stop it. And so that's why when people say pandemics are optional, they're not right now. They're absolutely not. When they're going to happen, they're going to happen. Now, our goal would be ultimately one day to have effective influenza and coronavirus vaccines that we can vaccinate well in advance, and they actually have the broad coverage of even new emerging strains. Then we could take pandemics off the table. That would be wonderful, but we're a long ways from that right now.
I remember when we used to have our calls in the height of the COVID pandemic, we talked about how buildings that were built in prior decades often did not consider air circulation. And as a result, a lot of offices, could be spreading grounds for COVID or other airborne illnesses. Have you seen, since the COVID pandemic, has there been any change in how builders and others are thinking about it? And what are the types of things that we should be doing to limit internal transmission by improving circulation?
Well, I wish I could be optimistic about this and say, well, this would be very important. There is so much that needs to be done, and the millions and millions of buildings around the world that house where we live, where we work, where we go to school, etc., for the 8 billion people on the face of the earth. Look at transportation. Look how many air flights there are. Look at subways and so forth. And while there are air exchanges that occur there, we still have only a limited amount of data and just how clean does the air have to be before you're not transmitting the virus. And just to give you an idea of what I'm talking about, we had a very unique experience here in Minnesota, which we recount in the book, to give you an idea what an aerosol is like. Some years ago, we had the Special Olympics for the world held here in Minnesota. And on the opening night ceremony, as held at the Hubert Humphrey Metrodome, there were 64,000 people in the stands, most of them from Minnesota or the upper Midwest. And there were all these participants who basically were in the infield, the outfield, etc., by team alphabet. So the A's were right on home plate, Argentina. There happened to be a 12-year-old young Argentine boy who was a participant who was just breaking with measles at that time. We had not had any measles in Minnesota documented in the previous 4.5 years. Well, needless to say, there was an outbreak that occurred among the participants in the Special Olympics over the course of the next 2 weeks, and it was really an unfortunate situation. But what was remarkable was we had some cases that the only contact they had with the Special Olympics was that they were actually at the opening night session. No contact with players, no contact with coaches or any other team officials. When we were able to identify these individuals and show where they sat, they all sat in one limited small section in the far upper right field area, where at the time Mark McGwire couldn't hit a home run on steroids at 420 feet. And it turned out that the air came out from behind home plate, and it kind of bounced at the home plate area, and it literally dumped 420 feet later up into this exhaust fan area. And our studies showed that it basically infected everybody in that section who had not previously been vaccinated or had never had measles. Now think about how infectious that was. And that's the kind of problem today to develop the kind of building air hygiene programs or the ability to minimize that we still have a lot of work to do study-wise to understand. It's not just how much air exchange occurs, but it's also, does it occur universally, universally in the sense of every room, every hallway, does it concentrate? And so, unfortunately, we've seen almost no investment in this activity since the pandemic to really understand this in a more comprehensive way. So let me just say, opening a window in a school that only has radiator heat, in the middle of the winter, that's not possible, but that's about the best you have right now on a systematic basis. Some places are using types of filter air devices that can help knock down some of it a little bit, but this is an area that's very, very rich for research. We need a lot more work, and what we don't want to do is spend money on things that don't matter. I mentioned earlier about these droplets. Well, a lot of people thought that that's the only way that the virus is transmitted. We spent millions and millions of dollars in this country putting up plexiglass shields that were meaningless, that had no impact whatsoever. The idea of the 6-foot distance, meaningless, had no impact whatsoever. And so I think that this still begs the question of when are we going to do this kind of research to find out just how good does a ventilation system in a building have to be, and what does good mean? And so this is a very important area of research.
We're going to take a quick break. We're asking listeners to take a short survey so we can serve you better. It's short, it's anonymous, and your input directly shapes what we cover, topics, guests, and how deep we go. If you work in government, at a think tank, or in the defense industry, your perspective is especially helpful. Tell us where more clarity and more depth would help your day-to-day. Please visit survey.bgsdc.com before Wednesday, October 8th, and share your perspective. Again, that's survey.bgsdc.com. Thanks for helping us continue to evolve the show, and we will be right back with more of our discussion with Dr. Michael Osterholm.
Beacon Global Strategies is the premier national security advisory firm. Beacon works side by side with leading companies to help them understand national security policy, geopolitical risk, global technology policy, and federal procurement trends. Beacon's insight gives business leaders the decision advantage. Founded in 2013, Beacon develops and supports the execution of bespoke strategies to mitigate business risk, drive growth, and navigate a complex geopolitical environment. With a bipartisan team and decades of experience, Beacon provides a global perspective perspective to help clients tackle their toughest challenges.
During the pandemic, we, talked about both the government role in pandemic response, but also the private sector, and also the cooperation needed between government and the private sector. Have you seen the private sector learn any lessons from the pandemic? Remember, we had supply chain fragility in medical goods and critical materials. Are they doing it on their own, or do they need that government, push to take the steps that would prepare the private sector to be ready for the next pandemic?
This is one, of the aspects of what would be a 9/11-like commission report that would want to go into this. We surely go into it in our book. But honestly, we have seen virtually no preparedness come out of this experience. The companies that make the respiratory protection that can be effective, the N95 masks as they're called, have basically stockpiled very little in that way. And they're not going to stockpile it until the government places an order. And that's the real challenge right now. We're seeing that with pharmaceuticals. In terms of vaccines, in terms of drugs that might be effective or more effective against COVID or influenza. And frankly, it's almost been limited. And what we are concerned is that the current U.S. approach on mRNA technology has even caused companies around the world to begin to abandon mRNA technology research, because if it's not going to sell in the United States, it's not likely to sell around the world. And so we're just walking away from this, not only from a standpoint of pandemics, but I just noted that 285 kids in this country died from flu this past year. We have not had a major improvement in flu drugs in years and years and years, and yet we surely need that. Again, unless the government's going to provide that support and move those along, it's not going to happen. So this is another area that's very ripe for additional concern. Investment is just what you just laid out.
From the government perspective, you mentioned that they're not prepared. They're not going to become the customer for these vaccines or for the N95 or KN95 masks. In a perfect world, what role should the government be playing, putting aside the current political hot potato that it currently exists surrounding the COVID pandemic and pandemic preparedness?
Well, one of the real unique gifts of being part of Beacon Global Strategies is being around really smart people like you, okay? And I say that because one of the things that I have no expertise in is defense. Well, when you look at the threats to this country, to the continental United States, or for that matter, the world, it's infectious diseases. More people have died from microbes in the United States in the last 100 years than have died from all the wars combined. And you would think that we would accept that as this is an enemy from within as much as it's a risk of an enemy from without. And why are we not investing more? When you look at the actual investments made in vaccines, in drugs, and so forth for these microbes, it's a mere pittance of what we spend otherwise to protect ourselves and the country from a defense standpoint. And I surely have no expertise in the defense side, so I accept when you tell me we need that, I believe you, okay? And your colleagues at Beacon Global Strategies, who are a unique group of very expert individuals in this area. But I can tell you from my area, we need a lot more investment. If we had, and I'm very careful about this because I don't know, we probably need more aircraft carriers, not less, okay? But if we had the resources that were invested for a 14-year build of an aircraft carrier put into infectious disease vaccine work, we could likely see major improvements in our vulnerability to these microbes. We're in a situation right now where we're seeing an ever-increasing amount of antibiotic resistance. The more that bacteria and viruses are exposed to antibiotics, not only does it help we kill them with these antibiotics, but they also then, in many cases, the microbe will develop mutations that change and now make it antibiotic resistant. We're at a point in this country right now where we have literally infectious diseases that we have controlled over the last 40 years with new and better antibiotics, that those antibiotics don't work anymore. We need a major project on developing new types of antimicrobial agents. We're not doing it. And the companies aren't doing it because think about the investment strategy. We're going to tell you to spend all kinds of money to make a new antibiotic or antiviral. But once you get it done, we don't want you to use it absolutely, and it's absolutely necessary so we don't make more resistance again. Well, who's going to go into that without some kind of government subsidy or some kind of government support? So at this point, I would just say that we have so much more that we need to do in terms of investment in this area. And I think, again, coming back to the enemy from within or the enemy from without, I would say that microbes will continue to be the number one cause of death of people in this country or around the world, not wars.
Yeah, your description reminds me that, the Spanish flu pandemic actually had a tremendous impact on soldiers during, World War I, and that, it can often impact military readiness and planning if you're not prepared for infectious diseases. You know
what, Andrew? There are more fighters, U.S. fighters, buried in Europe from dying from influenza in 1918 than died from the entire First World War. That's how much influence that virus had on what eventually transpired in that war. And that's, I think, again, from a fighter preparedness standpoint, you're absolutely right. This is why the Department of War Defense has, in the past, placed such emphasis on infectious disease preparedness.
In your book, you argue that the next pandemic will likely be even more devastating than COVID-19. Can you talk more about the thought experiment you used to illustrate the point of the book and what makes it plausible?
Well, let me qualify that a little bit. We could have another pandemic tomorrow that wouldn't be the big one, but the big one's coming. It's going to happen. I mean, again, as I pointed out earlier in our discussion, we've already identified new coronaviruses in the wild, in bats, that have that ability to be transmitted quickly and efficiently like we saw with COVID, and have the package on board genetically to kill the way that MERS and SARS does. That virus exists. We don't have to have some, evil sorcerer suddenly invent it. It's here. The question is, when will it spill over? Now think about the following. If you look at today's population, 8 billion people on the face of the earth, what you're talking about is a need to feed these people, a need in a crowded world to see what it looks like in terms of human contact. Feeding the people today. The number one source for converting energy to protein is poultry. We have become a poultry world. Well, it so happens that's where the influenza viruses like to start, avian influenza. They start in poultry. And so the fact that we now have so many more poultry on the face of the earth just to feed the world, we have now created this incredible major new factory for making flu viruses. And that's true around the world with other things. Bushmeat. Today in many of the low and middle income countries, bushmeat has become a main staple of their food source. Well, these are the same animals that are being consumed or even being killed and gutted and cleaned that also are harboring the kind of viruses that we're so concerned about. Bats, for example, because of their unique immune system and body temperature, carry around all of these viruses without being killed. They have rabies, they have Ebola, they have any number of viruses. We're seeing many more contacts between humans. And in fact, I have to say, I have a picture that I just received recently from someone where in an area of Africa where we're seeing Ebola right now in humans, there is a big quote-unquote fertilizing activity where the residents are in with wheelbarrows shoveling out bat guano out of these caves and then taking and sprinkling that on the field. Well, they got to be breathing just all kinds of virus coming in this activity. again, another opportunity for transmission. So we live in a world today also where, and by the way, in the book, I have to add, we have a number of air flights that people took to different cities relative to this scenario. These are actually real air flights. These are actually real numbers of people who are traveling on any one given day from around the world. So very few people realize that the airport at Turkey is one of the most busiest airports in the world, and it has all these people coming together. And so the other thing is that by the time we pick up on these things, they are all around the world, and that is so different than it was 100 years ago.
When we were talking about the pandemic and COVID at the height of it, there was a big debate about its origins. And, that has become a very political issue going forward, particularly whether this was a lab leak or not. How is the international community working together on pandemic preparedness, or has it become difficult because of the finger pointing and claims that, China hasn't been forthcoming, which by the way, they have not been. But how has that impacted cooperation in terms of preparing for the next pandemic?
Well, first, let me set the stage for this. I was on the National Science Advisory Committee for Biosecurity from 2005 to 2013. And I was very involved at that time with assuring that the NSABB as an oversight group would improve on lab safety in anything that was done in the United States or funded by United States support. And in 2012, I was among several that raised a very significant concern about research that was being done in H5N1 influenza virus, where researchers, for legitimate reasons, were trying to understand what changes would have to occur in the virus to make it become a readily transmitted human-to-human virus. Well, in the process of doing that, they were passing it through an animal model, ferrets, which tend to mimic much of how the human experience is. And we were very concerned that, yeah, this is great. You're going to give us some forecast of what might be coming, but in the process, you might make that forecast the reality if this leaks out of your lab. So I was often seen as a hawk on lab safety and the whole issue of what was going on. Well, now, fast forward to Wuhan. And I can tell you with absolute certainty, and I'm very convinced of this, we're never going to know. No one will ever have the definitive, bullet that was, caused this whole situation to unfold. My whole point is rather this whole debate has been terribly unfortunate in that it just holds us back from any other work. We're so fixated on arguing about Wuhan that we're missing the point that we have to be prepared for a lab safety leak in the future. We have to be prepared for a spillover in the future. What are we going to do to be better prepared for those? If that were the focus, that would be a lot better. But I'm afraid that we're going to still be talking about the Wuhan debate between a spillover and a lab leak for the next decade or more to come, with no additional information that's going to be satisfactory to convince anybody. Meanwhile, we are not going to be as prepared as we could or should be because we've been distracted by that.
During the pandemic, at the height of the COVID pandemic, there were a lot of debates over lockdowns, over the use of masks. It brought out political passions. And this is not unusual. If you read back to, the flu pandemic in the 20th century, there were similar arguments. How did we get past those in prior pandemics? And is there a path ahead for rebuilding a consensus on public health and preparedness going forward?
Well, of note, and by the way, the question you're asking is right at the heart of, I think, of so many issues around what happened and where do we go from here. If you look at the pandemics of the last 100 plus years, the 1918 influenza pandemic lasted better part of 4 years, actually. The hardest were the first 2.5 years, but it was still there. Following that, if you look at that, there were major breakdowns in civil discourse and how the public reacted to influenza. Okay, so it wasn't lost on me that anytime you have something that lasts that long, it will completely try the patience and the willingness of society to go along with whatever you're suggesting. That's just reality. Finally, you just go up and say, I've had it. If you look at since 1918, none of the influenza pandemics that we had were as nearly severe, and they didn't last nearly as long. So people kind of were, basically dismissed from class to say, okay, we're done now, okay? COVID is what changed that. COVID did last 3+ years. The new variants that emerged, Delta, Omicron in 2021, 2022, were actually more infectious and in some cases able to kill more efficiently than we saw in 2020. And so there was a constantly changing environment in which this was all happening. So, but I think that what was really a challenge here is we're seeing a lot of revisionists right now rewriting the history of COVID. This is simply not true. And I was at the table through the entire time, okay? So I can tell you with as much honesty as I can muster what really happened. And an example is lockdowns. This is crazy how we continue to talk about this. We have actually documented, it's in the book, the last lockdown that was officially implemented by a government body at the state level was actually finally done in June of 2020. So all 41 states that had lockdowns in the last week of March, basically by first week of June, they had actually relaxed them and no longer in effect. This did not last for 3.5 years, okay? But what did last 3.5 years was, in fact, people feeling scared to go into public. Remember, people were dying. We were having, 2,000 plus deaths a day during Omicron in this country from COVID. Hospitals were overrun. And so what happened? People naturally, in many cases, didn't want to go to work. They didn't want to ride in public transport. They were concerned about what was happening with essential workers that needed to be on jobs for, supporting our food systems, so forth. I actually made a plea to the director of the CDC with Omicron to be able to have people be able to return to work, not after 10 days of infection, but after 5 days if they were well enough and wearing a respirator at that time, because we didn't have enough healthcare workers. We had pharmacies in this country that were shut down because they were all sick. And so I think that part of the challenge we had was realizing that much of what happened wasn't a lockdown. It was about the fact that people acted out of fear of themselves. And so they wouldn't go to a restaurant. Now, some cities closed restaurants down, I grant you that, but it wasn't national. Schools never were a national issue. That was always a local issue where we saw legitimate debates between parents who were frightened to send their kids to school and parents who demanded that schools be open because of the loss of education experience. So I think one of the challenges we have to get around is, how do we deal with that in the future? What do we do to make certain that we have better communication, that we actually understand that? I gave you the example of snow days. I think the more data you can give to people, if everybody in your community knew your hospital is 120% capacity right now, you knew people were dying needlessly because they were in hallway beds or in parking garages, okay? That gave you a reason to want to pause what you're doing if you can, so that hopefully you can let that virus activity diminish in your community. We are not having those discussions for the future. We need to. We need to have a plan that says, if this lasts 4 years, how are we going to handle it? And let me just add, I wrote a piece in the New York Times that at the time got panned pretty good. As you know well, Andrew, a lot of my stuff gets panned. But in this case, the Chinese were, after 2 years, feeling great pressure to relax some of the very stringent stay-at-home orders they had. They had areas in China where, in fact, people were not permitted to leave their homes, and food was literally brought to them, food and medications. And finally, the social pressure got so great that they relaxed that, but they hadn't vaccinated their population. Literally within weeks, they started losing millions and millions of people dying from COVID because the virus was still there. Just coming out after 2 years wasn't enough to keep the virus at bay for 4 years, okay? And so I think that one of the things we have to also understand is we can't lock ourselves down in a way that basically just gets us through it. And that's what a hurricane's like. That's what a tornado's like. You do lock yourself down. just long enough to let it pass, and then you can go into recovery. This is going to last much, much longer. And that's why we need to really have these discussions and how does it, and we try to bring that out in the book in the scenario. We actually get into the inside of the White House. We get into the inside of the senior leadership of the government and say, okay, how are we going to deal with these issues?
You and I talked often about the advice that public health leaders were giving during that time. Has there been any reflection among the public health community about the intersection of public health and politics and government, and how to better frame the recommendations, how to better frame the options that takes into account the types of decisions that political leaders are going to have to make?
The short answer is no. It hasn't been done. It needs to be done. It needs very much all aspects of government, all aspects of life. One of the things that I think was a lesson that should have and could have been learned was the fact that public health can make all the recommendations they want, but they are not the only recommendations. You have to have the community leaders. You have to have others involved in deciding, is this something I will accept or not accept? How will this work? Even something as simple as the financial model of how do you get through the pandemic. With this country, we basically paid people to not go to work, okay? In Europe, they had a very different situation. They paid the firms where these people worked to keep them hired. And then, basically, they could come back much more quickly in recovery. And I think, and we talk about the economics at some length in our book of what were the lessons that could have and should have been learned about what were the economic costs of these pandemics and how might we better structure that type of activity going forward. So I think we have a lot more work to do to talk about how to talk about it. And right now, as you know, you and I deal with this all the time. This is the third rail. If you want to have a challenge discussion, get into what happened in the pandemic, but what could be done to turn it around. Why did over 1 million people in red states in this country die from COVID after the vaccine was available, beyond what we saw for the same population rate of deaths in the blue states? And it had to do with a lack of uptake of the vaccine. Why did that happen? I actually personally had 3 dear friends, individuals that I had spent a lifetime living with, learning with, and entertaining with, who just refused to take the vaccine, even though I had, many discussions with them, and all 3 of them developed COVID and died during the pandemic. What was that about? Why? And so we have a lot of work to do, I don't want to have anybody think for a moment I believe I have all the answers, but I surely have identified a lot of the problems that I think we could address if we were willing to do it and not let us just devolve back into at Wuhan, who did it and who didn't do it. And that's what seems to happen every time.
Well, thank you so much for taking the time to go over these issues. Again, Dr. Osterholm has written a book with Mark Olshaker, the big one, How We Must Prepare for Future Deadly Pandemics, which provides important insights and recommendations for how to prepare. Again, thank you for taking the time, and look forward to continuing the conversation further going forward.
Thanks a lot, Andrew.
That was Dr. Michael Osterholm. I'm Andrew Shapiro. If you enjoy listening to NatSec Matters, please leave us a rating and review. We'd love to hear from you. If you're interested in becoming a sponsor, please email our team at bgs@bgsdc.com. You can also find this email in the show notes. Please join us next week for another episode of NatSec Matters.
NatSec Matters is produced by Steve Dorsey with assistance from Ashley Berry. NatSec Matters is a production of Beacon Global Strategies.